Now, when I talk before groups, I often have my cell phone with me because you never know, even in the middle of a talk, you could have an emergency call, right? Tell me you don't believe that. The real reason I have this phone is because I want to illustrate a point. There are more cell phones in the United States than there are people. Even the panhandler across the street on the corner probably has a cell phone, but he probably doesn't have very good access to health care. In Dallas, Texas, I can walk into any one of a dozen places and get my cell phone repaired. I don't need an appointment. There's very little wait. It's high quality, low cost repair. There are places that will send someone to my home, to my condo, to repair my cell phone. There's a national chain. It's called Eye Hospital. The people who work for it are called eye doctors. And yet, if something happens to my body, did you know that the average wait in the United States to see a new doctor is 3 weeks? That's the average. And in Boston, where we've told that they've had universal coverage for many years now, the average wait is 2 months. Remarkably, 1 out of every 5 individuals who enters a hospital emergency room these days turns around and leaves before ever seeing a doctor because they get tired of waiting. Now, why is the market so kind to my iPhone and so mean to me? I think the reason is that this iPhone is produced and repaired in a real market with real prices, where entrepreneurs know that they can get rich if they satisfy our needs. Whereas over in healthcare, we have so suppressed the market year after year, decade after decade, that no one ever sees a real price for anything. No patient, no doctor, no employer, no employee. And we like to think that our healthcare system is really different from the healthcare system of Canada or Britain, but the truth of the matter is we're more alike than we are different. In the United States, we mainly pay for healthcare the way the Canadians pay for healthcare. In Canada, a doctor's visit is free. In the United States, it's almost free. Every time we spend $1 in a doctor's office, only 10 cents is coming out of our pocket. The other 90 cents is paid for by a third-party payer, an employer, insurance company, or government. And so in the main, we are paying for health care in this country not with money, but with time. And that's the way the Canadians pay for health care. We ration by waiting. We don't really ration by price. Have you ever noticed that when you go see one of the other professionals, the lawyers, the accountants, the engineers, the architects, that exterior area that you walk into is called a reception area, right? But at the doctor's office, what do we call it? Yes, all right. That should tell you something about how medicine is different from the other professions. We have bought into the idea in this country that other developed countries have also bought into, that people should never have to choose between health care and other uses of money. We have bought into the idea that the market needs to be suppressed. And in making that judgment, what we've forgotten is that when you suppress the market, when you suppress the price system, you elevate the importance of all the other barriers to care. Now, what do I mean by non-market barriers to care? I mean, how long does it take you on the telephone to get an appointment with a doctor? And then how many days do you have to wait until you see that doctor? And then how long does it take to get from your home or your office to the doctor's office? And once there, how long do you have to wait before you actually get care? Those are all non-market, non-price barriers to care. And there's a lot of evidence that even for poor people, those non-market barriers are more important than the fee the doctor charges. And let me just give you 1 or 2 examples. North Carolina Medicaid, a few years ago, needed to cut expenses. And the enrollees at that time were able to get from a pharmacy a 90-day supply of drugs, and they had a $1 copay. So North Carolina changed the deal, and they said, well, look, you can't get 90 days in one trip to the pharmacy. We're only going to let you get 30 days at a time. And they said, for each of those 30 days, you're going to have to pay $1. So what they did is they tripled the money price of care, went from $1 to $3, and they tripled the time price of care because now you have 3 visits instead of 1. And they did this at different times in different parts of the state, and so the researchers were able to tell that it's this time increase was significantly more important for the Medicaid enrollees than the money price. In other words, the non-price barrier was the more important barrier to care. Now, another study by the Center for Health Systems Change looked at what happened at the beginning of what we now call the Great Recession. And what they discovered was not that unusual in the beginning, that when you go into a recession, people cut back on their medical expenses. They make fewer trips to the doctor. They go in the hospital less often. And this happens in our country. It happens in every country. Well, when people on average see the doctor less often, go to the hospital less often, that means that it's easier for the remaining part of the population to see a doctor, enter the hospital. And so all those waiting times get lowered. And what they discovered is that when the waiting times got lowered, this was really beneficial to middle income and higher income people, but it was almost no benefit to lower income people. It's like we're in a waiting line, and the lowest income people are always at the end of the line. And that makes sense from a provider point of view, right? Because if you're a doctor and you're providing services, you know the Medicaid patient is going to pay you less, or Medicaid will pay you less than anybody else. So that's the last patient you really want to see. And a third example was a study of the CHIP program, and they discovered that when children went from other insurance or no insurance to the CHIP program, the amount of care they got didn't change at all. What matters in the CHIP program is what you pay the doctor, and if you pay more to the doctor, then these children get more care. Well, if the state can't afford to pay more to the doctor, what about the idea of allowing patients to add to the state's fee and pay more out of their own pockets? Keep that idea in your mind for just 1 second. In this country today, there are about 50 million people on the food stamp program. And people who are on the food stamp program can enter any supermarket that you and I go into. They buy essentially the same things we buy. They pay the same price that we pay. They go to the checkout stand. They put their food stamps down. They add money to it, or at least that's the way they used to do it. Now there's a credit card of sorts. You swipe the card, you add money to that, and they consummate their transaction. And we never hear it said in the United States that low-income people don't have access to supermarkets, right? I mean, the worst that's going to happen is they get on a bus and go a couple of miles. But you never hear it said that a supermarket is not accepting any more food stamp customers, right? That just doesn't happen. Now, over in the Medicaid program, we have about, these days, 65 million people on that program, but mainly they're the same people who are in the food stamp program. And over in Medicaid, what's the biggest problem? The problem is finding a doctor who will see you, getting access to care. If they can't find a doctor, what do? They go to community health centers. They go to emergency rooms of safety net hospitals. In Dallas, ours is Parkland. Here it's Grady. I don't know what it's like at Grady, but at Parkland, the average wait in the emergency room, if you're not bleeding all over the floor, the average wait is 4 or 5 hours, depending on the time of day and the day of the week. That's not really good access to care. I was in Massachusetts a year or so ago. I was in a taxi cab. There was a woman driver, and I began asking her, how is Romney Care working for you? And she said, well, she guessed it was okay, but she had a real difficult time finding a doctor who would see her. I said, well, tell me about that. And she said, well, Mass Health, which is their Medicaid program, gave me a list of 20 doctors, and I went down the list, and I gave me a list of doctors. I had to go through 20 before I found one who would see me. And I said, well, this come out of the telephone book? And it says, no, this is the list prepared by Medicaid. This is their list of recommended people to see. That really isn't access to care. Now, while that's going on in all over the country, in every state, we have about 1,300 walk-in clinics, and you have them here in Atlanta. In the CVS pharmacies, they're called Minute Clinics. And the reason for the name Minute Clinic is that they know that your time is valuable as well as your money. They have posted prices. You know exactly what you're going to pay. And it's a lot less than you would pay if you went to a doctor's office or to the emergency room. In Dallas, where I live, it's about $75 for a sore throat or earache. But the problem is that Medicaid only pays half that rate. And therefore, the Minute Clinics don't accept any Medicaid patients. Now, $75 is about half what we would pay if they went to a physician, or less, even with Medicaid rates, than we would pay. $500 is the average cost for the average patient walking into an emergency room. So this is cheap, it's quick, it's high quality. The studies show that nurses following these computerized protocols stick to best practices better than traditional primary care physicians. They can order electronically, prescribe electronically. We could hugely expand access to medical care for low-income people in the United States if we would just have Medicaid pay the market price that Minute Clinic and other walk-in clinics charge. All we'd have to do is just pay whatever the market price is. We know there's a market there. We know they're mainly competing for cash payments, so this is a real market as opposed to the rest of the healthcare system. And yet we're not doing it. You know, it reminds me of the couple that went to the doctor, and the man was in really bad shape. His arteries were clogged, his heart was weak, and the doctor called the wife aside and says, you know, your husband's in really bad shape, and he probably doesn't have long to live. But here's what you need to do. You need to cause no stress in his life. You need to make him as comfortable as possible. Don't nag at him, don't argue with him. Whatever he wants to eat, give it to him. If he wants to have sex. But he should have a very stressless life. So the couple's driving home, and he looked at his wife and he said, you know, you and the doctor had a long conversation. What did he say? He said, you're going to die. All right, we want to solve our problems. We've got to free the patient, we've got to free the doctor, and we have to free the entrepreneur. Doctors are the only professionals in our society who are not free to repackage and reprice what they offer to the marketplace. Every other professional can change what they offer, change how they price it, when demand changes, when technology changes, but doctors cannot. You know, it's probably been almost a century since all the other professionals discovered the phone. It's a really handy way to talk to clients. In fact, that's the main way I talk to lawyers. I don't go to their office, we talk by phone, if not by phone, by email. But we go through all of the 20th century, and even today, most doctors will not talk to you by phone. Now, with all those lights at me, I can't really see you very well, but do any of you know why doctors don't want to talk to you on the phone? They don't get paid for it. Very good. They don't get paid. And why not? Well, Medicare has a list of about 7,500 tasks that it pays doctors to do. And it turns out that on the list of 7,500 tasks, this phone is not on there. It's not on there in any reasonable, practical way. And the way Medicare pays is really about the way the whole private sector pays. It's the way the insurance companies pay, it's the way employers, we're all just piggybacking on the Medicare system. And since the phone is not on there, doctors are getting squeezed all the time by the third-party payers. They don't have time for unbillable hours. They can't afford the unbillable hours, and consequently, they avoid the phone. Email. By the time we get to the end of the 20th century, everybody's emailing everybody. Even the corner liquor store emails me if they think they have a bottle of wine I might want. Minute Clinic emails me, by the way. Minute Clinic will email me and say, hey, it's fall, it's flu season, have you had your shot? Or in August, school's about to start, you know, have your children had their shots? Or in the spring, it's allergy season. I mean, they email me telling me why I might need their services, but I never get an email from a doctor or a health plan. And why is that? You know, you guys were so good a minute ago. This is an easy pop quiz. You just keep repeating that answer, you're going to get an A on this exam. That's another thing that's not on Medicare's list of 7,500 things it pays doctors to do. And there's something else, actually quite a few things. Whenever you pay a professional in that way, which is the worst way to pay any professional to do anything, there are always going to be things that you leave off the list. I mean, you can't possibly think of everything you might need from a professional, or how they might do it, or possibly determine what the right price is, but that's the way the federal government approaches medicine. Do you all know any of you heard of Jeffrey Brenner? Again, I can't see you all very well. Hotspots, is that a word that's familiar to anyone? Somebody, yeah, okay. Jeffrey Brenner is this doctor in Camden, New Jersey, and I'm told that Camden is one of the poorest places in the whole country. And basically, everybody in Camden is either on Medicare, or they're on Medicaid, or they're uninsured. So hardly anybody has private insurance. Well, Brenner is a doctor, he's a scientist, he's inquisitive, he's also an entrepreneur. And Brenner goes down the list of hospital patients, and he discovers that over the course of a year, 1% of the patients were costing 30% of the hospital's money. So he began looking at the 1%, and he found this one guy. He weighed 600 pounds. This patient was alcoholic. He's a drug addict. He's diabetic. He's a mess. He spends half the year in the hospital, and the other half of the year he spends abusing himself. So Brenner takes this man and under his arm and under his wing, and he gets him off alcohol, gets him off drugs, gets him to go to AA, finds out the guy's a Christian, so he gets him going to church. He enrolls him in some welfare programs so he can have some financial stability in his life. And all of a sudden, this guy is not going to the hospital anymore. And so over the course of the following months, we're saving in Camden tens of thousands of dollars because this one patient isn't going in the hospital the way he used to go. And so Brenner thought about what he was able to do, and he established a clinic, and he got some help from some others. He got some private money, and he began doing this for lots of high-cost patients. These are patients that go to the emergency room a lot, they go to the hospital a lot, and they cost the system lots of money. And Brenner told me where the name hotspots comes from. Brenner told me he could drive down the streets of Camden and point to whole buildings. He could tell you how much that whole building is costing Medicaid and Medicare. Because it turns out that high-cost patients tend to live near each other for reasons I don't quite understand. But in any event, apparently they do. Now, I took the case of Jeffrey Brenner to this is before we had Obamacare. I took it to the Bush administration, and I said, you guys ought to think about what's happening here. And they said, well, what do you want us to do about it? I said, I think you ought to make Brenner a millionaire. For every dollar that he saves the federal government, you ought to pay him 10 cents, 20 cents, 25 cents. You ought to let him get really rich. And typical bureaucrat, and these are Republicans I'm talking to. And so they say, well, why would we want to do that? I had to carefully explain to them, well, because if you let Brenner get rich by saving money for the government and therefore for the taxpayers, and other doctors learn that it's possible to get rich by solving people's problems in this way, then you'll have doctors all over the country experimenting and doing some of the things Brenner is doing. Well, they thought that was the most radical thing they'd ever heard of, and therefore they wouldn't consider doing it. We didn't have Obamacare at that point. But now that we do have Obamacare, the principle hasn't changed. We need doctors to be able to repackage and reprice what they offer to patients and therefore to Medicaid and Medicare. And if we don't do that, we're making a huge, huge mistake. And incidentally, for Brenner, how much, for all the millions of dollars he's saving Medicare right now, how much do you think right now Medicare is giving back to Brenner? Close to zero. And Medicaid, there in New Jersey, for which the federal government's paying more than half the cost of that, but how much do you think Medicaid gives him back for all the thousands of dollars he's saving Medicaid? Again, it's almost zero. And why is that? It goes back to this original point I made. If you're not on their list, if you're doing something that's not on the list of 7,500 tasks they pay for, you don't get any money. And what I described to you a moment ago that Jeffrey Brenner is doing for his patients is really social work. It's not really medicine. I mean, there's some medicine involved. But the most important thing that had to happen there was Brenner changes his lifestyle. He changes what he's doing. That's what was saving the money. And since that's not on the list, Brenner doesn't get anything. By the way, the idea of making Brenner a millionaire, he called me up and he thanked me for that idea. But what the Obama administration is trying to do is trying to force Brenner to have an accountable care organization, an ACO, and it's just, it's sad to think about the fact that we have this entrepreneur who's being forced to become a bureaucrat, and more on that in just a moment. We need to free the patient, we need to free the doctor, we need to free the entrepreneurs. I'm often asked if markets can work in healthcare, and my quick response is it's the only thing that works in healthcare. Show me a healthcare market where there's no employer, no Blue Cross, and no Medicare, And that's very likely a market that really works well. Cosmetic surgery. Last decade and a half, the real price of cosmetic surgery just keeps going down, 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 as the real price of every other kind of surgery keeps going up. And you get a package price, you get transparent pricing. You know what you're going to pay before the procedure occurs. This real price going down is happening at a time when the demand for these services, it's increased 500 or 600% over 10, 15 years. You have all kinds of technological change of the type that we're told increases cost everywhere else in healthcare, and yet in cosmetic surgery, it's decreasing costs. LASIK surgery, same thing. Real price keeps falling. It's a package price. It's transparent. You have price competition. You have quality competition. It's a market that works well, and there aren't any third-party payers. The walk-in clinics we've already talked about. Those originated to serve the needs of cash-paying patients. Now, in time, some of the insurers decided, well, maybe we should pay for that. Medicare will pay, but not the market price. They pay a Medicare fixed price, which is whatever Medicare pays nurses to do. But that's the wrong approach. If minute clinics are solving a problem, if they lower costs, raise quality, increase access to health care, we want more of them. And if you want more of them to serve senior needs, you don't want to skimp on what you pay them. Because if you skimp, if you pay the lowest fee you think they will take, then they're not going to be expanding services to senior communities, and they're not going to be expanding their product line to meet senior needs. The online mail-order drug services, why do those exist? They came into existence to compete with local pharmacies for people paying out of their own pockets. They never would have done this for Blue Cross. We wouldn't have had minute clinics if we had to rely on Blue Cross. So we have this online mail-order pharmacy that's cutting prices, so it lowers costs, better safety record than the local pharmacy. So quality's increased, access to care is probably improved. All of this in the cash-paying sector. Now, once that starts, some of the third-party payers get in on the deal, and they're very much in on it today. But it's an example of entrepreneurship, solving problems, initially because they weren't dealing with third-party payers at all. Sometime back, when President Bush was Governor Bush of Texas, he appointed me to a blue ribbon commission to look at healthcare in Texas. And there were Democrats and Republicans, and conservatives and liberals. There was a cross-section of us on this commission. And one of the first things I discovered was right there in my own city of Dallas that Medicaid was paying some hospitals twice as much as it paid other hospitals for exactly the same service, and there was no apparent difference in quality. So all the hospitals told me that what Medicaid pays is really skimpy, but apparently we were twice as skimpy at some hospitals than other hospitals, and I couldn't quite understand why that was happening. And then I discovered that from Austin, we determined what every doctor in the Medicaid program was going to be paid throughout the whole state, all determined in Austin. And so our small group took a field trip. We went out to El Paso, Texas, which is on the border with Mexico. And El Paso is quite a big city, but it is hugely Hispanic. It is very low income and a huge number of uninsured people. So we went to some of the clinics out there that served Medicaid and uninsured patients. And the first thing we discovered is that in a typical clinic out there in El Paso, they had the ability to do almost nothing. They couldn't do a blood test, they couldn't do an x-ray, and that's because the fees from the state were so low, they couldn't afford those things. So patients, for simple tests that ordinarily you would think would be done in a doctor's office, they had to go to the hospital. And after a while, it was pretty clear why this was happening. The fees were too low for doctors, too high for hospitals. We were underpaying doctors, overpaying hospitals. And when you stop to think about it, anytime you have somebody in a distant city trying to guess what's the right price, they're never going to guess correctly, right? I mean, somebody's always going to be overpaid, somebody else is going to be underpaid, and if it's significant enough, you will completely change how people are getting health care, and that was what was happening. Now, another thing I discovered was that we had in Texas an any willing provider rule, which I think probably is true in every state under Medicaid. And what that meant was that once a doctor got into the Medicaid program, you couldn't kick him out. You couldn't accept. It was almost impossible to get a doctor off the Medicaid program. Once they're in, we don't have any procedure for doing that unless he commits horrendous acts. Contrast this with IntegraNet down in Houston, which manages Medicare Advantage patients. These are Medicare patients who are in private plans. And I learned from IntegraNet that they kick a doctor out of their network about once a month, at least one, and maybe more. Now, why are they doing that? Well, I'm sure it won't come as a surprise to any of you that doctors practice medicine in different ways. And some doctors are very conservative about how they practice medicine, and other doctors order every test, and they order brand drugs instead of generic drugs. And these doctors the 10% over here are costing the system lots of money. These guys over here are saving money. And so what all third-party payers want to do is exclude these high-cost doctors from the network. Well, that's what they're doing down in Houston. But it's not just excluding them from the network. I'm going to explain in just a moment. IntegraNet is aggressive managed care, and the doctor has to believe in a medical home, coordinated care, using electronic portals to communicate with other doctors. And if they don't want to do that, then they don't belong in the system. But in any event, we have one system, Medicaid, which never kicks anybody out. We have aggressive managed care, on the other hand, which is constantly changing its network to make sure that it lowers costs, improves quality, improves access to care. I also learned through time, because a Minute Clinic didn't exist back then, that Medicaid, like Medicare, is very, very slow to pay for any new technology, even if that technology saves money, improves quality, improves access to care. So basically, neither program will pay the market cost of a walk-in clinic. They don't pay for telemedicine. And I understand that you all, this state is one of the best states in the country for expanding the use of telemedicine. But basically, Medicare will not pay for doctors at the Mayo Clinic to get on Skype and get connected with rural hospitals in Minnesota and neighboring states to care for stroke victims. Now, some of you may know that when a stroke victim comes into an emergency room, what you do and how quickly you do it has a huge impact on that patient's future. So if you do the right thing and you do it quickly, you save that patient, and he'll have a higher quality of life, and you lower the cost of care, and that's what you want to do. So doctors at Mayo Clinic are doing this, and you get high quality care, low cost, and Medicare won't pay for it. And not only will Medicare not pay for it, but the American Medical Association thinks this shouldn't even happen. You know, down in Texas, Dallas is the headquarters of Teladoc. Teladoc is the largest national firm for telephone doctor consultations. They have 11 million patients that they serve. And the way it works is if I'm in Washington, D.C., and I run on a prescription, I need it refilled, I call a number. Within 30 minutes, a doctor calls me back. That doctor calls my records up electronically, so he sees my history, he sees what other doctors have ordered for me, and I can get my prescription filled. The Texas Medical Association is trying to close these guys down. I mean, their position is, just like the National American Medical Association, that a doctor should not be treating a patient if that doctor has not physically been face-to-face with that patient. I mean, this is like 100-year-old idea, or a 1,000-year-old idea of how medicine should be practiced. These are people who don't know what modern technology can do. Now, I looked into this because we're before the courts in Texas on this, and one of the facts that came out was that the Texas Medical Association thinks it's just fine if I'm a doctor and I go on a 2-week vacation and I have another doctor who's a friend of mine. I say, will you take my calls for me? And he says, okay. And so now my patients call this doctor. They've never met. He's not seeing any medical history. He's not looking at any electronic medical records, but he can prescribe medicine over the phone. They think that's just fine. But it's not just fine for Teladoc to do what it does, which is a safer, better, higher quality way of doing it. In any event, Medicaid is slow to take advantage of all of this, and where it's going, I mean, just every day technology is increasing our ability to lower costs, raise quality, increase access to care. We now have Uber house calls, and I don't believe you have them in Atlanta, but they right now are in New York, Los Angeles, San Francisco, and some other cities. It's coming here. And the way it works is, and this is especially convenient for you if it's night and weekend when you can't even get to the doctor's office. Within 1 hour, a doctor comes to your home, and the cost is $100. That $100 compared to $500, which again is the average cost of the emergency room, plus long waits. So we've lowered costs, we've made care more convenient, and it's probably higher quality. But Medicaid doesn't pay for that, Medicare doesn't pay for that, and the local medical association isn't even sure it likes that. So we have not only government, but we have the professional bureaucracy in our way. You know, it reminds me of the fact that the Yakuza in Japan, when one of their members commits a serious error, you know what they do? They sever a finger, and they present their finger to their superior by way of atonement. And I've often thought that, you know, if the members of the state legislature, members of Congress, members of the Obama administration, if they had as much honor as the members of the Japanese mafia, we'd have a lot less finger pointing. All right, privatization. I want you to be aware of 3 types of privatization because it's important. We use the same word to apply to 3 things that are really quite different. The general notion of privatizing Medicare and Medicaid is like this, and we're talking about 2/3 of all Medicaid patients are already privatized. They're in a private plan, and these plans are run by entities you know of, Aetna, Cigna, United Health. 1/3 of Medicare patients are also in these private plans. One reason why Medicaid has been privatized in this way is that when the Medicaid patients go into the private plan can have a narrow network. They don't have to take every doctor. They don't have to take every hospital. So they narrow their networks and they negotiate with the providers, but basically that's all they do. I joined a plan, a Medicare Advantage plan back in January. I know I don't look that old, but yeah, back in January, and I have maybe 5 or 6 different pills that I take, and I don't have a serious problem, but if I didn't watch what I ate and if I didn't exercise, I could have a problem. But I've been in this plan for, I don't know, 8 or 9 months now, and it's never contacted me to find out what's going on or whether the problem is serious or not serious. I just basically had no conversation with them. Well, down in Houston, Texas with IntegraNet, those guys, that's an independent physicians association. And there are a number of them around the country, and they're doctors, groups of doctors, and they're typically managed by an entrepreneur who may himself not be a doctor, but in any event, they aggressively manage care. And this would never happen in their plan. I mean, they would immediately have contacted me when I joined. There would have been a health assessment. If they discovered I had a problem, there would be regular follow-ups, probably tests to see how I'm doing, make sure I'm not getting worse. I mean, that's what they do. But the traditional managed care programs in Medicaid and Medicare are doing nothing more than negotiating prices, picking the network, and shuffling paper. And if that's all you're going to do, there's only so much you're ever going to save. Now, some of you know that the Obama administration, well, beginning with the Bush administration, but accelerating under the Obama administration, spending millions and millions of dollars on demonstration projects and pilot programs, trying to find out how to deliver medical care more efficiently. The Congressional Budget Office has looked at all this 3 times, and all 3 times it said it's not working. You're not saving any money. It's, they just don't know how to do it. But in the independent doctors associations, those things are working. Managed care, coordinated care, medical home, pay for performance, that stuff works when it is done by entrepreneurs who are motivated out of desire, quite frankly, to make money. And whereas in these pilot programs, no one has that motivation. So when you have the entrepreneurs, just like my cell phone, trying to get rich by meeting people's needs, we find huge innovations. And for a diabetic or a person with heart disease or some other kind of chronic problem, there's lots of attention. And if that patient misses doctor's appointments, doesn't refill a prescription, patient showing up in emergency room, they're going to be talking to that patient. They might send someone to the home. So it's aggressive management of patients with potentially really costly problems. And they are saving lots of money. Incidentally, all this happened, or part of the reason for the real increase in these independent doctors associations is a silly rule that's part of Obamacare. And what the silly rule says is that insurance companies like United Health and Humana and Cigna and Aetna, it's called minimum loss ratio and or medical loss ratio, and they have to spend 85% of all their premium income on medical care. And they only have 15% left for administrative costs and for their own profit. 15%, that's all they get. Now let's suppose that United Health discovered a way to cut healthcare costs in half through some miracle. They cut healthcare costs in half. What's going to happen? Well, the Obama administration is going to say, wait a minute, United Health, you only get 15%. Now you've got 50. You have to give us all that money back. Plus, because you were so bad that you tried to take 50 from us, we're going to impose a fine on you. So United Health has no incentive to really succeed at lowering costs. So they contract with the Independent Doctors Association. And the Independent Doctors Association can spend as much as it wants on administration. The Obama administration doesn't care. It counts all of that as Medicare. So if the Independent Doctors Association gets the medical loss ratio down to 75%, as they do down in Houston, or 65 or even 50, that's profit that they can keep. And they can even kick back some of that profit to United Health. And that doesn't count against the 85% rule. So they didn't intend for this to happen. This is one of the unexpected, unintended consequences. We're moving patients into organizations that aggressively manage their care and really are lowering costs and raising quality and increasing access to care. So that's one of the benefits. So the first kind of privatization is negotiate prices, pick a network, and shuffle paper. Second kind of privatization is aggressiveness in really trying to lower costs and solve problems in an efficient way. And the third type of privatization is the accountable care organizations that are set up under Obamacare. And although they never use this word, you never hear anyone from the Obama administration or the Democratic Party say that they're privatizing Medicare, but they really are. A third of the patients are in the Medicare Advantage program, but the other 2/3 are going into accountable care organizations whether they know it or not. If you're on Medicare and you have not joined a Medicare Advantage program, you probably have been assigned to an accountable care organization, even though nobody told you about it. And the accountable care organization is very limited in what it can say to you. Any letter it sends to you has to be approved in Washington. And they cannot exclude anyone from the network. And if you leave one doctor and go to another doctor, you may have switched accountable care organizations, although nobody told you about it. And it makes it very hard for an ACO to ever do anything if it has no control over what the patients are doing. And there's a limit on their profits. We cut their profits. We subsidize their losses. And what an ACO really is, it's what happens when liberals try to privatize something. By the time they get through, all the benefits of privatization are gone. Now you might think, well, why is it that if the Obama administration is so interested in finding newer ways and better ways to provide care, higher quality, lower cost care, if that's its goal, why isn't it focusing on the Medicare Advantage plans where this is actually happening? And part of the answer, I think, is that in 2008, when Barack Obama was campaigning for the presidency, he was running against the Medicare Advantage program, right? He said, we're paying those guys too much money. And so I think it's just too much of a political flip-flop. Now, if Hillary, she could have done this, I think. But Obama, no. And so we've ignored, or at least the administration is ignoring, the only part of the healthcare system which is aggressively trying to figure out how to deliver healthcare. All right, let's talk about Georgia for a moment. What can you do? I've already hinted at some things you shouldn't be doing, but beyond that, what can you do? I think you need to think about empowering the patient. You need to have health savings accounts. You need to let, first place, Medicaid ought to pay the market price for all of these market-based services, the freestanding emergency care clinic, the walk-in clinics. Wherever you have a real market with real prices that are transparent, there's no reason not to pay the market price, because that's going to be better than any made-up price that politicians and bureaucrats come up with. Plus, it lowers the cost of care, raises the quality, and so forth. So, empower the patient, pay the market price. But if you don't want to pay the market price, then let the patient add out of pocket to the administrative price, so that the total price is the market price. And then you have in Medicaid something called cash and counseling, and I don't know if you have it in this state, but you have it in most states. And what cash and counseling is, it's a Medicaid program where we take the homebound Medicaid disabled and give them a pot of money and say, you manage your own care. So they can hire and fire the people who provide them with services, and they're literally managing their own budget. And satisfaction rates in this program are like 96, 97%, 98%. They're really, really high. If that doesn't impress you, you need to know that if you go all over the world, you're not going to find any healthcare program anywhere where you get 98% satisfaction. I mean, that just doesn't happen, but it is happening in this cash and counseling program. We need to build on that and expand it greatly. I mean, there's a huge opportunity for people with chronic illness to manage their own dollars, not just the disabled homebound. Lots of opportunity here. The other countries are way ahead of us, especially on long-term care. What happens all over Europe is what I call don't ask, don't tell. In our cash and counseling program, we're looking at everything that happens, but in Europe, the more typical thing to do is say to the family, here's a lump sum amount of money. If you'll take this money and you'll take this patient, we are not going to ask any more questions. That's what long-term care means overseas. I'm not saying we have to do that, but we ought to. We're not taking advantage of the opportunity to let patients and families manage their own health care. Then here in Georgia, you need to open the market to the aggressive managed care companies, I mean the independent doctors associations, who are aggressively managing chronic illness, and give them the opportunity to serve your Medicaid population. But make it competitive. Let other companies compete with them. Just create a market outside the Obamacare exchange. And there in that market, you ought to get substantial savings, and furthermore, the amount that you pay ought to go down through time. In other words, the longer these guys do what they're doing, the better they get at it. And the better they get at it, the lower is going to be the total cost to the system. So they're doing things today that they just weren't able to do 5 years ago. So through time, your costs ought to be going down. Then I would let these plans be part of your Obamacare exchange, because the truth of the matter is between 100 and 200% of poverty, family income is going like this. So families that are qualify for Medicaid 1 month, 3 months later, they're not qualified and they have to go in the exchange. And then 3 months later, their income falls, now they're back on the Medicaid. And if you're bouncing back and forth like that, odds are they won't sign up for what they should sign up for. And even if they do, there's no continuity of care because there's no continuity of third-party payment. So let the plans that take your Medicaid patients also participate in the Obamacare exchange, but you could have this be an exclusive plan. I mean, they do not have to be open to everybody else. But anybody that's Medicaid eligible or that's going back and forth, they could stay in the same plan. You have continuity of third-party payment, and you have continuity of care. Those are just some ideas I think you ought to think about. As far as the expansion, I don't see anything wrong with taking the federal money as long as you can use that money in a responsible way, and that is privatize the system in the best way, empower patients, let the private sector companies that are doing a good job continue to do it, and I don't have a problem with that. Arkansas got a waiver to use their Medicaid expansion money for private plans. I don't see any reason why Georgia couldn't. My perception is the Obama administration is desperate for its health reform to work. And so many parts of it are not working that I think that if you came to them with something credible that looked like it would work, that you're going to get to do it. That's what I think. So those would be my recommendations. I was introduced as the father of health savings accounts, so let me just conclude and we'll go to questions by saying that health savings accounts are normally talked about as a financial issue. And it's certainly true that when people are spending their own money, they're more careful about how they spend it. They pay attention to prices. They're less likely to be wasteful. All that's true. But for me, the huge issue, or the more important issue with HSAs, has always been the issue of power. And I believe the healthcare system can be cold and impersonal and even threatening at times, and it may not work in your interests. And so my view is that if you control the money and you control the power to make your own decisions, the system is going to work better for you than if you cede that money and that power to some third-party payer. Thank you all very much.